Welcome back. We are so excited because today I have someone who I'm sure a lot of y'all have seen on social media. I'm sorry if I'm going to butcher your name, Dr. Lora Shahine?
Shahine. It sounds
Shahine.
like machine.
Okay,
Fertility
machine.
machine.
Jane, I literally was listening to your videos of you introducing yourself this weekend. And I was like, okay, Shahine. And then, of course, I say it wrong. So I'm sure so many of y'all know exactly who she is. If you are struggling with fertility and you're on social media, she has made quite a presence for herself, which is so incredible. We need more voices and doctors out there to share so much knowledge. So we appreciate you showing up on social media and doing everything that you have. And we're just going to kick it off. Can you kind of tell me a little bit about yourself? She is a reproductive endocrinologist. So kind of tell me how you got into that and a little bit about your background.
Oh, thanks. And first of all, thank you so much for having me here. I'm fangirling a little bit because I have seen so many of your videos on TikTok. I've done a lot of reaction videos because you do such an amazing job of combining humor and but also the hard parts about going through a fertility journey. So I really appreciate what you're doing, and I am so happy to connect with you today.
Yay, I'm so glad. You're so sweet.
Truly. So I'm Dr. Lora Shahine. I am a reproductive endocrinologist. I grew up in North Carolina, went to school in Washington, D.C., did the rest of my training in California at University of California at San Francisco, and then my fellowship at Stanford. And I ended up in Seattle at this incredible practice, Pacific Northwest Fertility, where I've been since 2009.
Wow.
So I have been helping people for honestly almost 20 years build a family. It is something that nobody in my family was in medicine or a physician, but I just always knew that I wanted to help people in that way. I really enjoyed women's health. I loved delivering babies. I thought OB/GYN was right for me. And then I was introduced to the world of fertility, and I just absolutely loved it. And just an incredible place to be, always learning, incredible technology, incredible way to help families.
Truly. Can you explain what a reproductive endocrinologist is?
Yes, someone who's been in school for a very, very long time. You go to college, get a bachelor's degree, then medical school is 4 years, residency in obstetrics and gynecology for 4 years. So that's where I was delivering babies and doing gynecologic care, surgeries, and things like that. And then instead of becoming an obstetrician or a gynecologist, I went on to do a fellowship in reproductive endocrinology and infertility. And that was my 3 years at Stanford. So it's subspecialty training beyond residency. And we are learning all about fertility, female hormones. We are the specialists in first trimester miscarriage care. A lot of people don't realize that. There are a lot of other doctors that focus on miscarriage, but that's something that we really, really learn about in our fellowship.
Wow.
So IVF, IUI, and a lot of help.
Okay, incredible. Can you tell us, for those that may not know, what is IUI, what is IVF, what's the difference, and who's a good candidate for both?
Absolutely. I talk about this every single day, and I've got a great video on YouTube called IUI versus IVF if you want to go and look at it again to kind of rehash it if I talk too fast. But I think anybody that's not conceiving within 6 to 12 months. I don't think people should have to wait a year, but if it's not happening pretty easily, at first they should really get an evaluation. So they should make sure the anatomy is okay. If your fallopian tubes aren't open, an IUI isn't going to work. And I'll go over that in a minute. But hormone testing, absolutely get a semen analysis very much at the beginning, because what is going on is going to really dictate what you do. If everything's totally normal, maybe you just try a little bit longer. But if you're going to do fertility treatment, I think about it as two buckets: low-tech fertility treatment, and IUI, or intrauterine insemination, falls into that bucket. And then high-tech, or IVF, in vitro fertilization. So at its core, the low-tech, which IUI is included, you're controlling some variables. You might give medication to help with ovulation. You might do ultrasounds to make sure everything looks perfect through the cycle. You might trigger ovulation with a different medication. But at the end of the day, you're washing and prepping sperm. and putting it into the uterine cavity. But I consider it low tech because everything's still happening inside the body. IVF is totally different. It's the most high tech thing that we have. And in that process, you're actually in one cycle stimulating multiple eggs to come forward, getting the eggs outside of the body, having sperm and the eggs in the lab. And so I think about it like what typically happens in the fallopian tube, egg and sperm meet, fertilization happens the first, 5 to 7 days of embryo development. What's happening typically in the body in the tube is happening in the lab. And then when the embryo is ready, you're still putting it into the uterus, but it's going through a different door. It's going up through the cervical canal and into the uterine cavity. So to answer who should do which treatment, it's very personal and people should talk to their doctor. But IVF was invented for tubal disease. So if your tubes are blocked, then the lab is a substitute for the tube. Another big category is very significant male factor. There are men out there that have a little bit of sperm in their ejaculate, maybe like less than 1 million, but that's not enough to get pregnant with an intrauterine insemination. And then there's so many other indications for IVF. One of the most common ones is really unexplained infertility because sometimes you just don't know what's going on, and IVF just controls a lot more variables.
Okay. And then, a question I get all the time, my husband and I, we've talked to many doctors, and IUI won't help us in our case whatsoever. And we just don't feel comfortable moving forward with IVF. And that's okay, to each their own, right?
Yes.
But I do think it's just such an important conversation to have. And I know so many women that are struggling with their fertility that follow me and listen to the podcast, want to know more. And that's why I'm just so glad we have you on, to have you as a resource. And I always love learning more about fertility. I feel like these last 3.5 years, going from someone who had no idea when I ovulated when we first started trying, to someone now who knows all these ins and outs about fertility, is just mind blowing, that I just love learning more and more about it. And I think it is such a good thing. I don't think it's so black and white. If we're not going to do it, we're never going to talk about it and not support it. I really think it's just such an open conversation. And it's something I think we should all be talking about and just learning more about. So can you talk about success rates? Because, a lot of people tell me y'all been trying for 3.5 years. Why wouldn't you just do IVF? And, we have talked to doctors about IVF as well. And the success rates we've heard for what's personally going on with me, they're so low. And I think, IVF is such an incredible resource for so many, right? Yeah. But it is important to have a doctor that's going to tell you the success rates for you and be very upfront and honest with you about it. So can you kind of go through the success rates here?
Oh, sure. Absolutely. And it depends on so much, as you
right.
know. But when I'm talking to my own patients about this, I give them a realistic baseline that if you are in your 20s, we should be our most fertile, and you are trying without any assistance, you're just having intercourse at home, the chance of getting pregnant in one cycle and having a baby, because I know your story. So, just seeing a positive pregnancy test does not mean that you have a baby. You could have a miscarriage. So the chance of live birth with a single timed intercourse and one ovulation is about 20% when we're in our 20s. So you have to kind of have that baseline. By the time we're 40, the eggs are 40 years old, and there is an age factor of sperm. It's just more highlighted with eggs. The chance of live birth with one try is about 5% each month. Can it happen? Absolutely. Right. But as we age, it takes longer to conceive, and there's a lot more variables. Right. So if somebody has been trying to conceive for over a year and they meet the diagnosis of unexplained infertility, their chance of getting pregnant with intercourse at home without any assistance is about 5% each month. Again, depending on a lot of different factors. Right. So if I have a patient with unexplained infertility, I say, listen, low tech treatment where we could give medications that kind of help pull forward the best egg, maybe make the estrogen and progesterone better in the luteal phase where your implantation is happening. If you're doing ultrasounds to make sure the lining looks good and make sure that the follicle is mature and it's got a great egg, and you do a trigger to make sure ovulation happens, plus you wash and prep the sperm and you're putting the sperm past the cervix. You can't diagnose a cervical factor, But if you're kind of mechanically getting the sperm closer to where it needs to go, you will double or even triple your chances of getting pregnant. So maybe going from 5%, it could be like 10, 15, even 20% by controlling those variables. IVF is totally different. And I know ethically it's challenging for people, financially it's challenging for people. There's so many reasons that people just are like, it's just not for me. And I absolutely respect that. But you can really control so many variables with IVF. So if you could get 12 to 15 eggs in one egg retrieval, that's like a year or more of trying, or a year or more of even intrauterine inseminations. And when you're trying with IVF, you know fertilization has happened, you know the embryo is developed, and even we have the ability to do chromosomal screening on the embryos. You can actually, I mean, it's like living in a science fiction movie. It's amazing. You can biopsy about 10 cells away from an embryo and make sure the chromosome content is balanced. It's not perfect, but you can really do that. So in my lab, and I'm talking to my patients like, hey, if you were to do IVF and you were to transfer a single screened embryo, your chance of live birth is 70%. And if you have more than one embryo and you don't get pregnant with that first try, you have to try again. You know, with a second try, the overall take-home baby rate is about 85%. So it's pretty incredible. But what's really, really important, and it's nuanced, and this has to be talked about with each patient. I did not say everybody's success rate with IVF is 70 or 85%, because there's a lot of steps to actually get to that screened embryo.
Right.
There are people that have significant diminished ovarian reserve, and they'll never get more than 1 or 2 eggs with any egg retrieval. So maybe they would get a euploid embryo, which means chromosomally balanced with one egg retrieval, but that's really unlikely. So that person might need to do multiple egg retrievals, to meet that goal. So IVF is by no means easy, free, or 100% successful, but it is drastically different from other treatment options that we have.
Yeah, absolutely. And I think that's just so important for anyone who's considering IVF or thinking about it or, moving forward with it. I hope that your doctor is very honest with you. And like you said, it is very case by case. It's so dependent on what you're going through. It's not like, I feel like a lot of people, including myself, when I was not knowledgeable on fertility in general, it was like, I would see these women who were trying for years and I was like, why wouldn't they just do IVF? Thinking it was like, 100% success rate. Like, why wouldn't you do that? And then I've followed women who've done IVF for years and years and years and have never been able to get pregnant. And of course, there are ones that do get pregnant, the first time and every time they do it. So like you said, it does vary just so much. But I asked my audience for a bunch of questions for you. So I'm going to just fire away. Okay.
Great.
Okay.
Shoot.
What are your thoughts on AMH?
Sure. AMH is not a perfect test. It does not tell somebody whether they are fertile. It doesn't tell you when you're going to go through menopause. AMH, anti-Müllerian hormone, is a hormone that comes from supporting cells around eggs in the ovaries. So the higher the AMH, the more supporting cells, the more eggs you have up for grabs any given cycle. So AMH is amazing at counseling, setting expectations for someone that wants to do an egg retrieval for any reason, whether they're freezing their eggs for fertility preservation or they're creating embryos to try to get pregnant right now. The higher the AMH, the more eggs we could get from one egg retrieval, and the higher the chance that someone could have a baby with one egg retrieval. So AMH is wonderful for me as an IVF doctor to counsel people about their options and expectations, but it is not a perfect test. We all want that fertility crystal ball that will tell me how many more years do I have, for my fertility, how long do I have before I use maybe IVF as a last resort, or, just kind of want that knowledge. And it's a snapshot in time.
Yeah.
And it really needs to be interpreted very well in everybody's personal situation.
Yeah. So I hope those that are listening hear that. If you were told you have a low AMH, that doesn't mean you can't get pregnant. Because, I was told I had a very low AMH. Like, unfortunately, we weren't able to keep that pregnancy, but my AMH has actually changed ever since I had laparoscopic surgery done. So, there are a lot of factors into it as well. But I think like one of the main questions I got is like, if I've been told I have a low AMH, does that mean I can't get pregnant? And you clearly stated no.
Absolutely. A
Yeah.
great study out of the University of North Carolina, Chapel Hill, years ago, just talked to couples that were planning to try to conceive, did an AMH for free, did not tell them what it was. Not that they were trying to hide information, but like, hey, this is a part of the study. And a year later, they went to see who got pregnant in that year and who didn't,
Wow.
and did their AMH predict it? And the AMH level, whether it was low or high, did not predict who got pregnant spontaneously, like without treatment. And so I would also warn your listeners that having a high AMH does not mean that you are fertile. So just no assumptions, and make sure you get the entire fertility checkup, because just because you have an AMH, that does not mean that your partner has sperm.
Wow, that's so good to know. Okay, Clomid versus letrozole.
Sure. Clomid is clomiphene. Clomid is the brand name. Clomiphene is the generic. It's been around since the 1960s. It's the first fertility drug, and it's what's given fertility treatment such a bad reputation for causing side effects, because some women will have headaches, mood swings, vision changes. A small metabolite of it can build up in your system over time, and it can cause, cysts or follicles that have a hard time kind of recovering. It can thin the cervical mucus, and it can thin the decrease the cervical mucus and thin the endometrial lining. So that's Clomid. Letrozole works the generic is letrozole and the brand name is Femara, works very similarly to Clomid in that it helps your body recruit eggs. It is considered a fertility pill, but it doesn't have as many side effects. It works in a totally different way.
So who do you generally, like what kind of patient do you generally prefer Clomid? What kind of patient do you prefer Femara/letrozole?
I almost always use Femara or letrozole, no matter who the patient is. But sometimes I will switch to Clomid if we're not seeing a good response with letrozole. Somebody, it's a discussion. This is a journey. We're on the same team. I want to try something different. Okay, great. But let's watch and make sure that none of those side effects happen. And some people come to me and they say, hey, listen, I had my first baby with Clomid, that's what I want to try. And I listen, like, that's great. Let's give it a try. You did okay with it. You didn't have side effects. Okay, we'll give it a try.
That's so crazy, because for me, letrozole, I had like the worst horrific side effects. Like it was so bad. And Clomid, like I had heard of so many people having bad side effects. I was terrified to do it after letrozole. But then with Clomid, like the only thing I had was hot flashes. And I was like, oh, this is a breeze. And that just goes to show you your body, like everyone's body is so different and responds so different. Yeah. But I do love how you are a doctor that listens to your patients so closely and well. Like, again, I think that's something that's just so needed. And fertility is just, it's so hard. It's so hard. So to have a doctor like you who is just so willing to listen and be on your side and advocate for your patients, I mean, that's huge. That's huge. So again, thank you for doing what you do. Okay. I saw a lot of questions about those that are having reoccurrent miscarriages. Unfortunately, what are with doing IVF? What are your thoughts on that? What would you look at moving forward?
Absolutely. So this is something that's near and dear to my heart. When I was doing my fellowship at Stanford, my mentor, who's still there, Dr. Ruth Lati, was opening up the Center for Recurrent Pregnancy Loss at Stanford. So I learned a lot being in the right place at the right time. I have a book all about miscarriage to kind of help patients advocate for their care, because it can be so confusing. It's called Not Broken.
Say it again.
Sure. It's called Not Broken, an approachable guide to miscarriage and recurrent pregnancy loss. And you can find it on Amazon. But I really did write it for patients to not be overwhelmed, to understand the testing that's out there, to understand controversies in care. And the most common cause of first trimester miscarriage is absolutely a chromosome imbalance in the embryo. If you do test pregnancies, it happens 60 to 80% of the time. But that is, of course, not everything. You know, you need to make sure the hormones are okay. You need to make sure anatomy is okay. But that really is the most common cause. Now, that being said, people will often do IVF in order to do the genetic screening of embryos to decrease the risk of miscarriage, but it doesn't make it zero. So miscarriage risk, I would say, in someone who's 40 years old and getting pregnant without screening an embryo, whether it's an IUI or naturally, the miscarriage risk is about 50% when we're 40. 25% no matter how old we are, 50% when we're 40, because as the eggs age, more and more of them make chromosomal mistakes when they try to fertilize with the egg. If someone does IVF at age 40 and they transfer a tested or screened embryo, their miscarriage risk is going to be less than 10%, but it's not zero. So you can still miscarry a screened embryo, and it's horrible, but it makes sense to me because truly we are just making sure that these chromosomes are balanced. There's 10 to 20,000 genes on every single chromosome. And Dr. Lati at Stanford, look it up. It's the HOPE trial. She has incredible NIH funding to do whole genome sequencing in people that are having unexplained miscarriages from tested or euploid embryos, or they tested the pregnancy afterwards and found out that the chromosomes were balanced, to look for single gene mutations that can cause miscarriage. So think about it. We have single gene mutations that cause cystic fibrosis, muscular dystrophy, spinal muscular atrophy, hundreds and hundreds of diseases. And this has got to be happening in embryos as well. So I really try to emphasize, and I believe it wholeheartedly, that the most common cause of miscarriage is something within that embryo, not something with the person that is trying to get pregnant. And that whole bias of anything that has to do with fertility is the woman's fault. You know, that embryo's got to be perfect. It's got to be my body that is rejecting it. I mean, there's definitely things that we need to learn and look into and believe, but doing something for 20 years and seeing so many patients that kept trying and the only thing that changed is with a new embryo or a new pregnancy and they finally had a baby. I really don't want people to feel broken. It doesn't mean that you don't do testing, that we don't keep learning and researching, but I really want people to hear that message.
Agreed. Miscarriage is not your fault. It is not your fault.
Thank you. And please look up that HOPE trial at Stanford. It is, it's fascinating and you can learn a lot and even enter it if you'd like to help others learn more.
Yeah, that's so interesting. Speaking of trials, this makes me think I saw you did a post about the egg retrievals podcast.
Oh, yes.
Yeah, what can you kind of share your thoughts on that a little bit?
Absolutely. It's
I found
horrific.
that so wild.
It's awful. So the story is that a clinic on the East Coast, women were saying that they were having horrific pain with their egg retrievals. And long story short, there was a nurse in the fertility clinic that was switching out fentanyl, which is a pain medication, with normal saline for her own use. And so these women really were having egg retrievals and other procedures without pain control.
It's insane.
And
insane.
Hundreds of women. And this is a amazing podcast. It's by the New York Times. It's by the Serial Network. I think it's a limited series. It's like 8 episodes. Yeah. But what I liked about it, and I did a YouTube reaction video on this too, because my tendency is to push away. Like, that's not how it happens in our clinic. You know, my patients and at Stanford, at UCSF, every clinic that I've done egg retrievals, patients get more than fentanyl. They are really, really, really asleep. And I was like, that's just awful. That's that one clinic. But there's such a bigger issue here. We need to listen to women. So it's not just that this happened. This is piling on decades and hundreds of thousands of years of women's symptoms being dismissed. You know, pain is all in your head. Oh, people are supposed to have pain with periods. You know, a delayed diagnosis of endometriosis for 7 or 8 years is on average.
It's insane.
We just can't. We can't just listen to that story for its shock value.
Right.
We have to listen to it and say, oh my gosh, this is reflective of so much that's happened in society. And how do we make this better? How do we listen to women and pay attention to their symptoms?
Yes. Gosh. And if y'all are interested in listening to it, it's called The Retrievals. I think I said the egg retrievals earlier. It's called The Retrievals. It's super
Right.
interesting, but definitely a trigger warning too if you've gone through
Mhm.
IVF and have pain and all that. So it's very interesting. Okay. I'm going through IVF and I have had egg quality issues over and over and over again. How to get the best results.
Oh my gosh. When you figure it out, please let me know. This is like the last frontier in, fertility treatment. And not really. We need to pay attention to sperm and men so much. They've been so ignored. But you know, IVF does an amazing job depending on the tools that you're working with. If you've got great eggs and great sperm, you have such a high chance of success with your first transfer. IVF doesn't make the eggs better. It doesn't reverse aging of eggs, just like it doesn't make the sperm better. It doesn't reverse everything that happens with sperm as well. And there are so many fads out there. I mean, fertility patients are so vulnerable. I was one, I'm a trained doctor, tons of research. And when I was going through my own fertility journey, I still would kind of see like, oh, maybe I should, try that supplement. Maybe I should do that. You just feel
Oh,
so out
yeah.
of control that you just want to take back control.
Oh, yeah.
And so I just really, I think there is no substitute for just overall health and well-being. Like, think about your nutrition, think about your exercise, think about your mental health, manage stress. You can't eliminate it. Do take a prenatal vitamin, think about your vitamin D, maybe coenzyme Q10, but be very careful where you're sourcing supplements because it's not
Yeah.
regulated by the FDA. Find something that's third-party tested. So people get frustrated when, even as I'm their doctor, and they're like, tell me what to do. And I'm like, well, we can try a different IVF protocol. We can try this supplemental medication. But I want to be very transparent. There's still so much that we have to learn.
Yeah. And, that's what we suspect as an issue with me, egg quality. And
Mhm.
it has been like such a journey to go on because you really are kind of just throwing things at the wall, like trying to figure out. But I do love how you really emphasize, taking care of yourself and your body through nutrition, exercise, stress management, sleep, vitamin D, all these things, supplements. Like, it's so important. And I do want to point out how she said it's really important to figure out where you're sourcing your supplements. Y'all, like, truly don't just go on Amazon, find the cheapest one and order it. Like, please, 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 please go find the ones that are third party tested because it's so important. It's so important. So I'm glad you brought that up. Okay. Besides a trigger shot, what are other ways to induce ovulation when going through IUI or natural cycles?
So a trigger shot is really the only intervention that I'm aware of that can actually help with ovulation. I mean, the way the egg ovulates is typically a hormone from your pituitary gland called luteinizing hormone
Mm-hmm.
gets released once the estrogen levels from that mature egg reach a threshold. So, first 2 weeks of the cycle, the egg is maturing, the ovaries are making estrogen to get that uterine lining nice and thick and ready for implantation. The egg is maturing, the estrogen levels are going up, going up, going up. And when they get to a threshold, the pituitary gland pumps out luteinizing hormone to signal ovulation, release of the egg. And so the trigger shot is really just emulating, giving a hormone to simulate that luteinizing hormone.
Mm-hmm. Okay, that's great information. How long should one try before consulting doctors? This is one I'm so passionate about.
Oh yeah, I don't think you should wait personally, but
I agree.
I know all over everywhere, every guideline is to wait 12 cycles, 12 a year. Try for a year. And I appreciate that because the stats do show that 85% of people will conceive within the first year of
Right.
trying. So if you do just try for a year, the majority of people will conceive. People who should not wait a year is if you're not ovulating. If you
Yeah.
are not having regular, predictable monthly menstrual cycles, um, and or have a hard time trying to figure out when in the cycle you're supposed to try. People with PCOS, and they're not ovulating regularly. The very first interview I did for my podcast, Baby or Bust, is with Karen Jeffries from Hilariously Infertile, an incredible account to follow when you just need a laugh because fertility is so flippin' hard.
Yeah.
She said that she basically wasn't getting pregnant, wasn't getting her period for a year, but she kept doing pregnancy tests because she's like, that's the only reason I can think that you're not getting a period. And it took her a year to see a doctor and figure out she had PCOS. And so don't do that. Don't wait.
Yeah.
Other reasons that people should go sooner is, honestly, if you're age 35 or older, the recommendation is to go after trying for 6 months. And the main thing is that you just have a shorter fertility potential the closer you get to 40. So it's sort of like, make sure you're not missing anything like really poor sperm counts or blocked fallopian tubes or things like that. It doesn't, just seeing a doctor and getting testing doesn't mean that you're like absolutely having to do treatment. I think that's one of the reasons people hesitate to see a fertility doctor is like, oh, she's just going to tell me I have to do IVF. She's not going to answer my questions. And that's not true. A lot of it is just, education, fertility checkup. So I personally don't think anybody needs to wait, but a lot of people honestly will conceive within the first 3 months of trying. So it's like 50% or even 60%. And so maybe give it, again, track your cycles, regular cycles, give it good 3 to 6 months and then just don't hesitate to see someone.
Okay. I love that. I know I'm so passionate about that because it's like, oh my gosh, the first doctor I went to after my miscarriage, she was like, no, you have to go through 2 more losses, which that was just like wild for me to comprehend. And then, or like wait for a year. And I was like, no, what if this is just low progesterone? Like, I don't want to have to like chance, losing it again. Right. So I think that's so important. So truly, listeners, like what feels good for you? And then if one doctor tells you, doesn't listen or hear you or tells you like IVF is your only option, like we have an RE, very well-known RE who's been doing it for 20 years sitting with us right now who's telling you that shouldn't be their answer. So advocate for yourself, go find someone else. Like finding a good fertility doctor is one of the most important things you will do in your lifetime. Truly. Besides raising those beautiful babies, but truly like finding someone who's going to advocate for you and see you and hear you. Like this journey is already so hard. Okay. Let's see. When to move on to IUI or IVF?
Sure. It's very personal for each patient and their situation. We already talked a little bit about the difference between IUI and IVF. So if there is tubal disease or a significant male factor, you might just bypass IUI and go straight to IVF. I think that a lot of the decision is personal comfort level, diagnosis, age, family goals too. So if I see a couple that is close to 40 and they want to have 2 children, or more than one child, I'm talking to them about IVF really soon because if you think about it, if you do conceive without intervention or with an IUI and have a baby at 39 or 40, that's amazing. That is fantastic. But you're trying again 2 or 3 years later, and fertility drastically changes after the age of 41, 42, 43. So it doesn't mean that they, do IVF, but I just want to say, hey, I just want you to think about it. IVF is the fastest way to get pregnant now. And then you also could have embryos frozen to to add to your family in the future. We don't know what your fertility is going to be like in the future, but it doesn't mean that you do it. But I just, just took a couple of patients early in my career who were so happy that they got pregnant with an IUI and then came back and dramatically struggled for baby number 2. And they're like, why didn't we think about, freezing earlier? So it's just a discussion. It's not that everybody has to do it.
Right. What's your best advice for someone who's coming to a reproductive endocrinologist or just a fertility appointment in general for the first time?
Yes. Number 1, bring something to write down with. If you have a partner, bring your partner. 4 ears and 2 brains is better than 1.
So true.
I get nervous when I go to see doctors, and I am a doctor, but I still just like get nervous. So I do, I always write down what medications I'm taking and allergies, kind of basic history, like surgeries and stuff. So we don't spend precious time talking about like, oh yeah, I forgot I'm taking, vitamin D or whatever. So I can hand it to them, write down questions, like that you really want to make sure that you talk about. I always open every consult I have with, hey, we're going to do a lot of talking, a lot of educating, but before I start asking questions, what are your goals for the visit? Like, I don't want to spend, I have like 45 minutes or an hour with a new patient. I don't want to spend all of that time me just chatting. And at the end of it, they're like, so what I'm really curious about is blank, so just not missing that. And then also just really, really kind of listen to your spidey sense. There's some red flags out there. If you're feeling dismissed, if you're feeling like the doctor is annoyed by you asking questions, listen to that. And you don't have to stay with the first fertility doctor or first fertility clinic that you see, and just listen to, how you feel and how the communication goes.
Yeah, that's really important. Gosh, I've had my fair share of not great doctors, so important. Okay, 2 more questions and we will wrap up. What are your thoughts on a patient who comes to you that's just been told they have unexplained infertility? I know we've kind of talked about this a little bit, but like,
Yeah.
what would your approach be moving forward with that patient?
First of all, I'm so sorry. It is so frustrating. Like, you kind of come to the fertility doctor so you can figure out what's going on, so then we can fix it so you don't have to keep not having a baby. So just recognizing that frustration. Also recognizing the fact that fertility testing is so basic. Are you ovulating? Do you have eggs? Is your anatomy okay? And do you have sperm? But if you do have those components, anything can happen. Like, just sort of recognizing that. Like, my grandmother tried for 20 years in the 1920s and 30s and finally had my dad when she was 37, which was ancient. In the 1930s, her friends were having grandchildren when she finally had my dad. So I look at that, and
so crazy.
It is. But I think about it in a lot of different ways. And I love sharing that story because also when I was growing up, I was in Winston-Salem, North Carolina. She was in Nashville. And anytime there was a new fertility breakthrough, she would always cut it out of the Nashville newspaper and send it to me and be like, look at how amazing this is. I kind of wonder if that's a little bit of a reason of why I'm doing what I'm doing. Because but what she was trying to say to me is like, I wouldn't have waited 20 years if I had access to this. That is not for everyone. But I just think, but also it did happen for her. And she did everything. She was in rural Kentucky. She went to New York to try to see doctors. She went to, witch doctors, in the middle of the woods. Like, she did everything. And it just finally happened. So unexplained infertility is one of the hardest things to go through. And fertility treatments really can be helpful just because it's controlling more variables. I think people can spend a lot of time, energy, and money trying to find that answer. And I hope that happens for them. But also at the end of the day, these fertility treatments could help with a variable that, might not be 100% known, but they could still be successful with the treatment.
Okay, last but not least, I almost didn't share this question, but I think it's really, really important. Someone asked, what nationality do you deal with the most of having infertility issues? And I before you answer it, I just want to say, I thought in going through infertility, it was just me. It was literally just me, right? And I remember when I had my miscarriage, not a lot of people were talking about miscarriages online, and it seemed like the profiles I was finding, they had their rainbow and they're talking about that beauty, but not like the hard in between. So that's really why I started to share. And I remember just getting messages from women, and it was like every ethnicity, every age, every background. Like, doesn't matter how much money you have. I had a TikTok go viral like last year, and Barbara from Shark Tank commented on it. And she shared how she's dealt with infertility. And it's like, it doesn't matter what color you are, how old you are, the amount of money you have, like infertility doesn't discriminate. So thought I would add this in, hear your 2 cents as well.
So you literally took the words out of my mouth. I was going to say infertility does not discriminate. You can be any age. So there's a lot of age discrimination in fertility. Oh, you're less than 30. You're fine. Just keep trying. And they've been trying for 4 years. You know, you don't know, like there can still be an issue. It can affect any ethnicity. And I'm so thankful for people of color really starting to share their stories. Michelle Obama, you know, so many people really sharing, Gabrielle Union, you know, the difficulties that they're going through. One of my favorite interviews for my Baby or Bust podcast was with Chiquita Lockley, a director and producer and filmmaker who did an incredible documentary about the fertility within the Black community and how people don't really talk about things. You know, it can affect any status, like wealth. I mean, look at Meghan Markle, a part of the royal family, having a miscarriage and having difficulty conceiving and finally sharing that. It can affect you at any weight. You know, there's a lot of being overweight discrimination and, you know, fertility, and people can be very, you know, heavy and be very fertile, or be very thin and be infertile. So like, it can truly affect anyone. And I think that's one of the wonderful things about you being on social media. You know, thank you so much for sharing all that you do. You really put yourself out there, but think about all the people that are unable to talk about this with their friends and family and loved ones because they carry around so much shame. And so the fact that you're doing that, you're helping people feel less alone. It's really important.
I totally agree. So I want, this is also a very important add-on to that too. You know, a lot of people are like, I don't get how, you know, there's like a crackhead, she's getting pregnant, or someone who's eating McDonald's every single day is getting pregnant, or someone who's super overweight or really skinny or whatever it may be. It's like comparison is the thief of joy. So, sitting here comparing your journey to anyone else's, I think it's so great to learn from other people's journeys, find comfort in other people, but really, really try and not compare your journey to anyone else's. Because, like almost every question you answered today, it was like, well, it depends on the person, like it depends on your body, which is, I mean, that's what infertility is. Like it really is so dependent on your body. And that's why there's just so much more to learn and so much more discovery to happen. So, okay, anything else you want to add in here at the end?
Oh, well, you know, Adelaide, I just appreciate so much being here. And for anyone that is listening to this right now, you are not alone. Infertility, miscarriage is not your fault. Take the time that you need and build your team, your support team, to help you. And I really hope that people hear that message.
Amen. Okay, where can people find you?
Absolutely. So my website, drlorashahine.com, my YouTube channel, just everything's in my name, Instagram, TikTok. And then I have my own podcast. It's called Baby or Bust with Dr. Lora Shahine. And I love interviewing and going into deep dives. So if anyone listening to podcasts here, you know that this is an amazing podcast. I so appreciate what you and your husband are sharing. But you might learn a little bit of something over on my podcast too.
Absolutely. Absolutely. I know. And people ask me all the time, like, what are some other podcasts that you listen to? So I love your podcast. I've listened to it for so long too. So thank you again for being here today. I know how busy you are and we ran a little bit over time. So thank you so much for your time. We so appreciate you and your advocacy for this community.
Thank you for having me. I really appreciate it.
All right, you guys, we so appreciate y'all listening and we'll see you next time.